if anybody has got any questions for our speakers, if you could say who you are, where you're from, and then direct your question to the relevant speaker. Thank you. First one's at the back.
Hello, I'm Matt Butler. I'm a consultant geriatrician at Adam Brooks Hospital. I've just got a question for John Otter, if that's okay. So, in the week to the 23rd of April, so that's just the Saturday just gone, just under 1 in 5 COVID cases in hospital were acquired after 7 days, so meaning likely hospital acquired, and that's NHS COVID-19 hospital activity data. However, the trust you work at seems to be consistently a top performer, so only 1 in 65 patients develop hospital-acquired COVID, according to Tom Lawton, who's a consultant anaesthetist at Bradford. So my question is, what are you doing locally to lead to such low rates? And in particular, can you say whether you use respirators for close care for COVID-19 patients, and whether your trust uses HEPA or have looked at ventilation improvements?
Okay, can you hear me? So I didn't hear that question brilliantly well. It was a bit muffled at the front here, but I think I got the gist. So Guy's and St Thomas's has a relatively low rate of hospital onset COVID infection compared with other London trusts. I can't fully explain why that is. I think it's good news. The organisation has very, very strong frontline ownership of the IPC agenda. And I think that's probably the root cause, because it's not just COVID, there's low rates of all reportable healthcare-associated infections. So you'd expect that kind of horizontal approach with good infection control all of the time. I mean, that's aspirational. We have our issues, of course, every trust does. But I think I'd probably attribute it to really strong frontline ownership of IPC and antimicrobial stewardship as well. Your second question about FFP3 respirators, we recommend FFP3s for all direct care of COVID-19 patients, and that's been the case since December, just as the Omicron wave emerged.
Thank you. Do we have any more questions? Yes, there's a question here, please. I've got 2 questions. If you could bring the mic down, please. Thank you.
Hi, my name's Emma. I'm work in a children's hospice in northwest London. I just wondered about the AGPs and why oropharyngeal suctioning is not anymore an AGP. Can someone explain that to me?
Who would you like to direct that question?
I don't know, it's been mentioned, AGP has been mentioned a couple of times, so I just wondered why that was changed.
I'm happy to have a go. I don't know the answer. I wasn't involved in the national review of the evidence, so there's been a recent national review of the evidence around what is an AGP, but it's not what is an AGP. It's what is considered a procedure that has an increased risk of generating an infectious aerosol. So there's a lot of medical procedures we do that generate aerosol, no doubt, but there's then a judgment call to be made as to whether that creates an infection transmission risk. As I said, I can't really talk to the specific procedures. I do know that the new list only includes suctioning beyond the oropharynx on the AGP list. So yeah, by implication, suctioning above the oropharynx is not. And I suspect, I'm guessing now, but I suspect they're saying it, yes, it generates aerosol, but that's not considered to be an increased transmission risk.
Okay, so it's the aerosol rather than the content?
It's aerosol rather than infectious aerosol, I'd imagine.
Thank you.
Thank you very much. And I think we've got time for one more question. And then I don't keep you from the stands because I will also get in trouble. And also your coffee. So last question, please. Thank you.
Okay, thanks. If I may, I might have 2 questions. My first question is, I am Marissa Alexis. I am the strategic lead for IPC for North Central London Integrated Care System. When studying the correlations between oral health and patient outcomes, for COVID, did your research distinguish between the different variants? And if so, was there any anomalies or inconsistencies? So my second question, if I may, is for John. On the back of your transmission slide, one of the speakers yesterday suggested that the difference in exposure between droplets and aerosols was negligible. I just wonder what your opinion was on that. Thank you.
Okay, should we do the oral one first?
Yeah, so I heard part of the question about variants. So what I was showing you and the data that I presented to you, or the concept behind what I'm talking about, was really related to alpha and delta, or alpha really, before, or the early variants. pre people being vaccinated. And so what I was talking about is the pure disease, as it were, not in a vaccinated population. Now, I don't know much about variants. My study has been based on the anatomy and, again, trying to gain an understanding collaboratively across different medical specialties, which is something that has not happened, to try and understand how the disease develops. And that was really just on the basis of observations of what was going on in the lungs and trying to educate, because that's my role as an educator, just to explain to people what was going on. And just explaining to people that this isn't pneumonia, this is something completely different. This is a vascular disease. And they said, well, that fits with the hematology, that fits with the ITU physiology, that fits with the respiratory disease, and so on and so forth. We are in a different position now. Before the end of this year, at the end of last year, in our hospital, we were still seeing 3, 4, 5 cases of exactly that pattern every day. That's become a rarity, but it does still happen. And I think there's some inkling from the Hong Kong data that those who are not vaccinated who get Omicron get a similar disease. So I think the disease pathogenesis is the same. In terms of what you do about it, the Cardiff data, what they've looked at is the lipid membrane of the virus, which is what nobody else has done to such a degree. They found that it's the lipid membrane of SARS-CoV-2 is packed full of procoagulant phospholipids to the extent that they express phospholipids to the same extent or 12 times to the extent of the outside of an activated platelet. And in vitro, the lipid membrane is directly thrombotic. They haven't extrapolated that to being in the body. They can't make that assumption. But there are many, many different mechanisms by which the virus itself could be directly thrombotic. Omicron is different because of the way it gets into the body. It infects, as I understand it, more cell types in the mouth and in the upper respiratory tract, whereas before that, it was really just the neuroepithelial cells that express the ACE2 receptor, hence the loss of smell, and how now Omicron is more infectious because it can get into more cells in the body. Whether it causes exactly the same disease is very difficult, but the surfactant mouthwashes, which have been shown to disrupt the lipid membrane, they get into the molecules, these phospholipid molecules. They just burst the virus. It just disintegrates. So surfactant mouthwash, they've said it doesn't matter which strain you're dealing with, it would still work in the mouth. So I hope that answers some of your questions.
It does, thank you.
And to the second part of the question about exposure to droplets and aerosols carries the same risk. I think droplet and aerosol have become such charged terms that I think we need new terms. I propose we talk about blobs instead of droplets or aerosols. So virus-laden blobs in the air of varying sizes, because I think that reflects the reality. I think the difference between the relative risk of transmission with different blob sizes will vary with a number of factors. So the patient, what you're doing to the patient, what the patient has done in terms of their disease course, and of course the organism as well. So I think there is still a fruitful discussion about a meaningful distinction between the behavior and the infection control implications of different blob sizes, but I think to dichotomize that to droplet and aerosol is perhaps not very wise.
Thank you.
Thank you very much. If you could thank our speakers, thank you.